Good afternoon, and welcome to our 7th live event for iGeriCare, where today we're going to focus on risk of falls in dementia. I am Dr. Anthony Levinson. I am a neuropsychiatrist here at McMaster University and co-creator, along with Dr. Rich Stramko, geriatrician from Hamilton Health Sciences. And we actually have a special guest today who I'm going to introduce shortly. But in the meantime, I want to cover a few things just about the topic and the process, some housekeeping notes. We'll be here live for about 45 minutes today, and you can send us your questions, comments using the chat box on the iGeriCare events page or using Facebook commenting. So please send us in your questions. We will try to address these as best as we can during the 45 minutes. There will also be a video recording that you can watch later. We usually post it on igericare.ca/events in a couple of days. So if you don't get a chance to stay for the whole broadcast today, you'll be able to review the video in a few days. A few other housekeeping things. We offer the iGeriCare.ca platform and these live events and the videos as an educational service. We want to help caregivers of people living with dementia, but this does not constitute medical advice. So we're trying to, if you give us very specific medical questions, we'll probably try to make them more general and educational. And if there are urgent issues, you should definitely check in with your healthcare team for specific medical recommendations. Okay, so on to today's topic on the falls and dementia and identifying those at risk for falls, strategies that caregivers might be able to do to help with that. And Dr. Stramko, maybe start off with just a few general statistics about falls and the relationship between falls and dementia.
Sure, I'd love to. I think one of the big issues that people will talk about with respect to falls is that they think of them more as a motor function or a muscle, bone, joints issues, or I tripped and fell, but they don't really think about how important their brain is in coordinating all of the activities and how your brain processes visual information. You know, your eyes need to see certain amounts, but your brain actually does all the hard work to put everything in context. The brain allows you to plan steps, so you don't think about it when you're walking down the hallway and you're talking to a friend or you're doing something else or you're distracted by something and then something else happens to you. Well, you may have the executive function to be able to process and multitask those things appropriately, whereas if you had some cognitive impairment, you wouldn't be able to do those things. So people that have dementia or cognitive impairment are 5 times more likely to fall than people that don't. People that fall with dementia are 3 times more likely to experience some sort of fracture, usually a fragility fracture from thinning of the bones as we age or osteoporosis. And then people that have cognitive impairment or dementia that fall are 5 times more likely to end up hospitalized or in a long-term care facility than those that have dementia that don't fall. So cognition and cognitive impairment are really important functions in terms of putting you at risk for falling. And then if you do fall with cognitive impairment, there are really severe outcomes that can take place, such as if you have a hip fracture, well, you're going to need to go in a hospital and you need to get an operation. When that happens, you're at risk for a whole bunch of other things. So let's say a pneumonia or some sort of urinary tract infection. So it's kind of really important to deal with the upstream aspects and trying to prevent falls, identifying people that are at risk of falls early so you don't end up in those unfortunate sets of circumstances later on.
So some great points there. In lesson 1, where we give an overview of some of the different cognitive elements, you identified a few already that, this is more than just movement in terms of falls. This is about visual spatial ability, knowing where your body is in space. It's about how your brain interprets things in the environment that you might trip over. It's about, as you noted, that executive function. So can you plan things? Can you stop yourself from getting out of bed and hitting a railing? And people with dementia may have their judgment impaired that might lead them to put themselves into a situation where they're more prone to falling. So a lot of different things that can lead to increased risk for falls.
A few other things I think we mentioned that were in the lessons as well. So we have used the term apraxia, which is your inability to do more complex motor movements, despite the fact that you're strong enough and you can sense, where your arm is at in space, and you don't have problems with coordination. It just means that these pre-programmed motor patterns that you've learned over long periods of time, you're not able to do them anymore. So you might have difficulties using a remote control or using utensils, but it also may impact your limbs and your ability to walk. So there's something where your feet may get stuck to the floor called magnetic gait or walking apraxia, and then motor apraxia, idiomotor apraxia is where you have clumsiness in your hands or potentially in your legs, and that can also impact your or increase your risk of falling because you can't coordinate properly.
One of the other, we have two other lessons, the first lesson, lesson 1 and lesson 5, where we talk about the different types of dementia. And it's probably worth highlighting that some types of what we call reversible conditions that may lead to cognitive impairment may also present with increased risk of falls. And then the different types of dementias may also have slightly different complications that are also associated with falls. Is it worth saying just a little bit about that?
Yeah, definitely. So Alzheimer's disease is our kind of prototypic type of dementia, and that's really where you'll experience the executive function problems that we discussed, the visual, spatial problems we discussed, the apraxia that we discussed. That's kind of the classic things we've described. There are also many types of dementias that are associated with Parkinson's-like symptoms, or in fact, Parkinson's disease itself is associated with dementia and has a subtype of dementia. And if you have slowness of movements or bradykinesia, or if you have some sort of tremor or stiffness, you won't be able, and postural reflexes, you won't be able to right yourself quickly enough, or your muscles may be too stiff and you may end up tripping and falling. There's also walking abnormalities or gait abnormalities where people will tend to speed up, or it's called festination when people are walking as well.
You see that sometimes people with Parkinsonism or in walkers where all of a sudden they seem to speed up, or at least they kind of lose control of their walking, and if they're using a wheeled walker, sometimes they can start to speed downhill.
And there's also freezing gait where people will all of a sudden get stuck and stopped, and as they're trying to get going again may topple over. Another problem associated with Parkinson's disease or the Parkinson's-like dementias are that they have drops in their blood pressure. It's called autonomic dysfunction. So their blood pressure may drop or their heart rate may be unpredictable. And if you stand up and your blood pressure drops, you don't have enough blood getting to your brain, and so you can fall over. So that's very important as well.
That's great. So I want to thank you for this brief cameo, and we're going to keep going, but I'm going to introduce our guest in a moment. So
thanks for having me.
Strampa.
Yeah, that's great.
Just a couple of things. So the different types of dementia we talked about, and vascular dementia or having strokes can also make people weak on one side or unaware of their surroundings on one side, which are risk factors for falls. A couple of the potentially reversible conditions that are really important to assess for. One of them that we've talked about in the lessons is vitamin B12 deficiency, and that can cause problems with sensation and nerves in the feet or hands. So again, somebody might not feel where their feet are in space and might be more likely to trip because they're not really sensing the position of their feet. Similarly, one that you may have heard of called normal pressure hydrocephalus, or NPH. This is a condition that causes a buildup of fluid in the brain and is also associated with cognitive impairments, unusual walking and falls, as well as incontinence. So those are a couple of the conditions that are really important to assess. So at this point, I would like to welcome our special guest, and I'll give you a brief introduction. So Dr. Alexandra Papaioannou, welcome.
Thank you.
And Alex is professor in the Department of Medicine and a geriatrician at Hamilton Health Sciences, executive director of the Geriatric Education and Research in Aging Sciences, or GERAS Center at Hamilton Health Sciences. She holds the Eli Lilly Research Chair at McMaster University, has been past chair of Scientific Advisory Council of Osteoporosis Canada, past chair of the board, intimately involved in the Ontario osteoporosis strategy, particularly around fracture prevention in long-term care, and the lead author on the highly referred to osteoporosis guidelines 2010-2015. So welcome as our first guest to iGeriCare and today's topic. We do have questions coming in live, but I'm wondering if there's maybe, Dr. Stramko covered a little bit about some of the conditions that can lead to an increased risk of falls with dementia. Is there anything else that you want to add as kind of key tips or things that you've noticed in your experience that you can give to caregivers about the risk of falls in dementia?
Right. I'm delighted to be here. Thanks for inviting me on this important topic. And so some key tips around falls for caregivers are really, how common is it? When should you be worried? The first thing is about 30% of people over 65 fall.
In general, irrespective of whether there's a dementia.
Yeah, and so, the first fall is sort of a signal. But if you have a couple of falls in a year, that becomes worrisome. And then you really should do things like see your family physician, have your blood pressure checked. Has there been any new medications added? And remember, when you take over-the-counter pills, they can really affect your blood pressure. Things that we think aren't worrisome can be worrisome when you're mixed with the drugs that the doctor prescribed. Review your medications. Have your vision checked. A lot of people haven't had their glasses checked in a long time. And people with dementia may not always remember, even people without dementia, to clean their glasses. And so
that's not a personal comment, but good tip. Yeah.
Good tip.
Yeah.
But that's something that people with dementia or memory problems may forget. And so those are really key tips. And then another common thing that we as healthcare professionals don't do and family members don't do is look at the feet. Take the footwear off. Is the footwear appropriate? So now in the hospitals, we often give patients non-skid socks. And so at home, a lot of folks will wear shoes that increase the risk of falling. So that's really important to think about. And then also think about what things can you modify in the home environment. I was always interested when I asked people, how did you break your hip? I'd say about 20% of people broke it around an animal.
Okay.
So they slip and trip walking their dog or the cat running between their feet. So not that you want to keep your pet, but think about what things can you modify.
That seems like a tough one.
That's a tough one.
Yeah.
But often, what's the right leash? Do you have rugs at home that people skid on? Those are important things.
Okay. Well, why don't we go to some of the live questions, and then we may circle back to some other great tips. So here was a question from Toronto. Are there resources for family caregivers to take their families and or clients in the City of Toronto and Hamilton that don't require a referral? And or what are the options besides waiting for a referral to, say, a more formal falls prevention program?
Right. So that's a great question because families are often wondering, what should I do next?
Yeah.
So your pharmacist can often be a great person to start with. Take all your family, your pills or your parents' pills with you, as well as anything that's lying around, to have them reviewed. And so you can book that appointment with the pharmacist, and they can review that.
And they might identify some of the ones that are maybe putting somebody at higher risk
That's
for
right.
confusion or
That's
falls.
right. The other important thing is most of our community health centers have programs, fall reduction programs.
I feel like contacting your local YMCA really around
Exactly.
the country, those would...
That's
Yeah.
a great tip. All our senior centers have fall prevention programs. Some are in chairs, some are standing. And so if it was a pill I could prescribe, I would prescribe exercise.
Okay. And we'll talk a little bit
and we'll
about some of
talk
the exercises.
So just for families to be aware is it can reduce falls by 20%.
Exercise. Wow.
So which is pretty, I don't think there's much we do in medicine that can have that effect. So that's a really quick tip. And you as a family member can call your local LIN or home care provider to have an assessment done if you're really worried.
And I think you can do that. You can self-refer.
That's right.
But probably some of the other suggestions you provided might be something you could do in the meantime with the pharmacist or the YMCA. The 211 service is another one that tends to be available nationwide and also in multiple languages. So in Ontario, you can pick up the phone, call 211, and you have a trained sort of community resource expert who can maybe direct you towards available programming. So.
And so there's often, our local public health departments all have often, and here at McMaster University, we have a website that you can check with some quick falls tips. What to check in terms of your house. You know, is there rugs that are putting somebody at risk?
Right.
Is there places that you can check out yourself? Often the bathroom is a high-risk place for falls. You might think about a bath chair if you can't get access to home care very quickly.
So those are some active things you can do while maybe waiting for a more formal assessment. So here's another question. Will a walker help? And how do you get someone to use a walker when they think they don't need one?
So that's a very good question. And this sounds like a caregiver.
Yeah, a caregiver running up against somebody who is resisting the walker.
So often individuals with dementia will often, even when they're fitted for walker, will forget to use the walker. And they sometimes don't learn how to use the walker. So involving them in when you get the walker chosen. So sometimes what we find is that people will buy one at a garage sale or have one from a parent or their husband or wife. And so they need to be fitted properly because they often are not. And you can often do those in some of the pharmacies have home health areas that you can get fitted properly. And then the third is to try and get people using the walker by pattern. So take them for a walk with the walker and use it repetitively.
Make it a routine.
A routine.
Okay.
So the new learning for somebody with dementia can be challenging. So we often will hear that is we bought this walker, but they're not using it.
And I think there's certain things that people tend not to teach them how to use it properly. So when to lock it, to unlock it. So I've had patients where they forget that it was locked, so they're trying to push it against resistance and they abandon it because it doesn't glide smoothly, or they try and get up and they haven't locked it and they may lurch forward on it. So there's definitely a few things to know. Any other tips for overcoming resistance?
Well, the one common thing my patients tell me, regardless of age, is they don't want to look old. And so a lot of people think that using a walker makes them feel old.
The stigma.
The stigma of using a walker. So again, trying to take some practice runs together and see that boy, you know, we got to the grocery store, we got to the corner store, and you wanted to get there by using the walker. Or do something enjoyable together so they start becoming familiar with it.
What I've noticed too with patients who start to use it is they immediately notice just how common it is, and which normalize it. It's like, you know, I went to the play the other night, or I went to the grocery store, and I noticed a lot of other people with walkers, which can help to destigmatize it if they're making a transition. So
that's a good point.
So here's a question from Kanata. What would be the best way to conduct an analysis of the underlying causes of falling in order to provide appropriate intervention?
So, you know, that is a really good question. And in working with older individuals with dementia, and in general with falls, it's never one thing.
That's why we love our geriatricians, because it is so complex, isn't it?
That's right. Yeah. And so we like to look at both modifiable things and non-modifiable things. So things at home is to try and still go through these. Is sometimes you have to do multiple things to reduce the falls. So doing things at home like checking the lighting. You know, is the lighting, does it reduce glare, limiting shadows? Often we won't have any contrast between our rugs and the stairs. And so sometimes what we'll do is we'll put a tape, just like we have here in the studio, to delineate where the rug and the chair and the stair is.
Just as another visual cue, so you don't hit the carpet
Right.
and skid or trip on the edge of it.
That's right.
Okay.
And keeping pathways clear. Our older generation has sometimes grown up in the war, has been used to holding on to things because they're worried that they may need things. So removing clutter from our pathways at home is really important. If there are mats, securing them with double stick tape. If there is a walker, what a lot of my patients will say to me is, my walker bumps into the furniture. So do a dry run with the walker in the house.
We spoke a little bit about some of the changes to the brain that affect people with dementia that may interfere. And so you talked about the vision and the cleaning of the glasses and make sure if they need glasses. But Dr. Stramko was also talking about, you know, people may have these visual spatial things. And I think that's what I've seen, that there's clutter in the home, but even if there isn't, there may be lack of awareness in their visual space, so they may bump into things with a walker or trip on objects that way.
So that's a really important comment, is people with dementia start having problems with their executive function, the front part of the brain, which really does then affect you. So doing things like walking and talking at the same time becomes challenging.
So we talked a bit about back to the question about assessment, quite a few different domains, looking at blood pressure and general health. I spoke a bit about, you know, the peripheral nerves, like feeling in the sensation. You talked about like looking at the feet and the footwear. Medications are very important. So just a lot of, the assessment is complex, and then the interventions, the things that you can do as caregivers, sounds like checking out and doing what you can with the environment, whether it's in long-term care or at home. Lots of great ideas.
Yes, right. So you triggered, the other thing is to ask a simple question. If there's new drugs added, especially blood pressure drugs or heart drugs, does your parent or loved one become dizzy when they stand up?
Okay.
So if there was a fall, what were they doing before the fall? So sometimes, especially when people get up at night to go to the bathroom, or in the morning when they stand up, that's when your blood tends to pool. You'll have a sudden drop in your blood pressure.
Okay.
And some people will say, I don't feel dizzy, but I feel really tired instead.
You talked about just the high numbers of older adults that fall, the frequency, and Dr. Stramko talked a little bit about just the increased risk with dementia. if you had to pick out sort of the many things we've talked about, is it known sort of what are the most likely culprits? Is it typically medications, or typically is there a sense of what the usual suspect is? Or
so we know people with dementia have a much higher rate of falling, 3 to 4 times, because of the executive.
Okay.
That center of our part of our brain doesn't tend to coordinate and plan, help us with the walking.
Maybe make some poor decisions about
That's right.
getting up in the middle of the night.
Yeah, and sometimes that automatic, we think walking is automatic, but it's sometimes, those are the kind of things that exercise, what we call functional exercise, can really help with.
Okay, so let's talk a bit about functional exercise, and maybe talk about it in the ideal world. So if we were able to do, like a caregiver could work with somebody and do functional exercise,
Right.
and then we'll talk about troubleshooting, because I imagine
Right.
there's a few challenges with somebody depending on their level
That's
of cognitive impairment. So what's a functional exercise?
So a functional exercise is simple things like, can you get out of a chair?
Okay.
So practicing getting out of a chair requires that our quadriceps are fairly strong, or even going to the bathroom, you need to be able to rise.
Okay.
And so sometimes people can't, and that may be a trigger that you need a chair, some support at the toilet.
And if they can't, it's most likely because they've got weakness in their
That's
large
right.
muscles and the
That's
leg
right.
muscles.
Yeah.
Okay.
Because that's the other thing with dementia that is often very frustrating, is that people appear to be not motivated.
Okay.
So somebody who was really active before, now and they live alone, may just sit in front of the TV all day.
And we talk in one of our lessons about apathy.
That's right.
And Dr. Stramko and I talked about that in one of the live events. And so if they're sitting a lot and they're not moving much, that would be one of the causes where their muscles get weak if they're not using them as often.
That's right. So really, it's once a week is not enough. We know you need about 150 minutes a week for balance and strength training. So, you know, if a program a couple of times a week, doing walking is very good. So if somebody has a walker, walking with them. And it's helpful. We know resistance training for Alzheimer's disease and mild cognitive impairment is one of the interventions that has the strongest research behind it.
In terms of preventing falls specifically?
Yeah, preventing falls, and also perhaps slowing down the delay in memory.
And there's some data around mood effects as well, potentially. So.
There's some latest research has just been published in the American Geriatric Society specifically around looking at the research around falls and dementia. And they found that really it has to be strength, it has to be resistance training, the balance, and when I say function is things that you need your muscles for to do at home, everyday activities.
Getting up, sitting down, getting back up, going to the washroom.
That's right.
So it, I feel like it sounds easier said than done. What are some of the, let's start with like mild cognitive impairment. I feel somebody might be quite motivated, could follow instructions, you could have a program. What are some of the caregiver things to do?
Right. So the Alzheimer's Society has great programs called Minds in Motion. At Osteoporosis Canada on our website, we have videos that you could do or grandchildren can do with their grandparents. Exercises for people well into their 90s, from 50 to 90s. We have a program called Geris Dance that's across our region, and that's at the local YMCAs, that is specifically for people who are a bit frail with memory changes. As well, the LIN has Safety at Home program where they'll come into your home and make recommendations.
There might be a waiting list for
and there may be a waiting list for that. Looking at the outpatient rehabilitation clinics, if somebody's falling more than a couple times a year, really flagging it to the family physician. we do know that a lot of older adults are fearful of sharing that, or they may have forgotten they fell.
Okay.
And so some people are fearful that they may be moved to a retirement home or long-term care. So sometimes it's not shared with the family physician.
So it sounds like there's a mix of programs that may have a waiting list, but could give you like a more formal assessments and exercise programs. And but there's also resources through the Alzheimer's Society or community resources like the Y that may offer help with getting started with an exercise program, maybe something that caregivers could in fact do on their own in the home to encourage. So we'll come back and talk a little bit more about some of the other types of specific exercises. There's another question here. Any suggestion for what to do if and when someone does fall? It's like, should you try and help somebody up? Should you call for a professional and not try to help? Is there any sort of general guidance you have on what to do if you discover your loved one that's fallen?
So it depends. How long have they been fallen? So some people we find, have been there on the floor for 6 hours to a day to 2 days. So if somebody's looks quite like they've been there and you haven't lost contact for them for a day or so, you may need to call 911. Okay. And if they're not able to move all limbs.
And if it's more recent and they're able to answer you, would you try and guide them to see if they could get themselves up or at least assist you?
That would be ideal. Yeah. But if they're having pain or they seem different than their usual, it may be important to seek
emergency help. Okay.
The other important thing is to think about lifeline or some sort of alerting system.
Yeah, and those types of, I guess there are different types of alerting systems. Do you have a sense of, some of them involve a thing that somebody wears on them, like a necklace, and they can sort of push it and it's linked to the telephone system.
That's right.
So that's one type, and you have to make sure that the person has the wherewithal to push it, which, depending on what has led to the fall or their level of confusion, they may not activate it. Can you say a bit about, there are some kind of contemporary wearable devices, right, that they even have sensors on them that may automatically sense when somebody's changed position or fallen.
Yeah, and so, I think that, I don't know your experience, Anthony, but I know sometimes I've had patients have these beautiful wearables and you go in to do a home visit and I have one, and you're
in
making
the back
those
drawer somewhere.
Or they're like, it just doesn't go with my outfit.
The battery ran out and I don't know how to charge it. Yeah.
And it's also because it's new learning and somebody with dementia may not use it. So I think that the wearables are going to be more and more in the future. I know the Alzheimer's Society has a number of products that are available or they can recommend.
I feel we're maybe, there are some really successful examples, but we may be about 5 to 10 years before smart homes with smart sensors can send sort of real-time data that suggests that somebody's position changed rapidly, so it does seem right now it still relies on the consumer a little bit too much for some people with dementia.
But I think that the question is, we have some patients that fall frequently and they live at home. And so talking about a strategy with the family, sometimes we can look at the underlying cause, but sometimes we can't take away that risk totally. And talking about strategies if they were to fall. Who would you call?
Right.
How would you try and get them up? When would you not get them up?
Kind of having a bit of an emergency falls plan.
That's right.
Kind of thing. Okay. Yeah. In terms of other types of exercises, we have a few things here that we talked about, and maybe you can just speak a little bit to some of these. So one of the things we were talking about here was posture awareness, and Is this something, how would the caregiver sort of work with somebody with their loved one to help with that?
Right. And so some of the posture awareness, especially Osteoporosis Canada, sometimes when people have fractures, their backs will be starting to curve and they'll have height loss. And when you have that problem, you'll start tending to tip over.
Okay.
But also people with dementia will often, I know Dr. Stramko mentioned it, is that they'll start shuffling a bit, they'll be a little more curved, their center of gravity will be off.
Their awareness of their posture and their ability to correct it is sometimes affected. Yeah.
So there are some specific exercises that you can do around posture, but if somebody's starting to look like this, is really focusing on the balance exercises. So that's a tip off if you know you're starting to say, gee, mom or dad is starting to shuffle a bit, not look like they're normal. I really need to get them into a balance program.
Okay. And again, a lot of the resources, either through 211 across the country, through the Y, many of those balance programs are available through community centers and don't necessarily require, you know, a physiotherapist or an occupational therapist or a referral. Would you say that the walker, if it's fitted properly, may help a little bit with posture?
Certainly it can. If it's not fitted properly, it can make posture much worse. Make it worse. Yeah, but it can certainly, often people will say, gee, I can now walk a lot further. My back isn't as sore when I can walk, and I can sit in between.
And what, I mean, just to kind of move to another example, here's an image of a specific balance exercise. It seems like this is something that somebody with cognitive impairment could be shown how to do. It seems relatively simple. This is basically standing on one foot but with support.
With holding on to a chair. The other, and if you can't do that, you can do what we call weight shifting, is sit in a chair and lift one leg up and then the other leg.
Okay.
And that shifts your balance enough that you need to strengthen your abdominals to do that. So people that can't be as mobile as this, there is still balance exercises you can do.
And that can still help to give them a bit more strength.
And so one of my patients with dementia, who was quite impaired, loved dancing. So she and her daughter would dance every day. And dancing is actually an excellent balance exercise. So think about if they like to dance, balance, that really helps your balance. Exercises like Tai Chi for people with earlier memory changes can be very helpful and have been shown to reduce falls.
Yeah, it does seem complicated to follow all of the movement. I guess, you know, I remember doing it many years ago and it seemed complicated to follow the movement. So I guess has it been adapted for people with cognitive impairment?
So for the earlier people with earlier changes. So important to pick a program that your loved one can participate in and not get frustrated.
And then you talked a bit about the importance of strength training or sometimes resistance training. I guess you don't need fancy weights to do this. You don't need a gym. Here's a couple of examples of sort of simple things where you're really using a lot of your own body weight.
And so we can see the squat. That is for somebody a little fitter. But if you can't do that, you can do as simple as, I'll hold on to this and have Dr. Levinson demonstrate. It's just try on a chair that doesn't have wheels to try and get up, even using the armrest.
So using the hands and just sort of push a little bit and
come back down. And do 3 to 4 of those.
Sort of like a backwards push-up.
Push it up, and while you're watching television.
And it seems safe because if I don't move myself forward too far, I'll fall back into the chair.
So that's another option. For somebody who is very what we call frail, or you're worried or has had frequent falls, that patient may need a physiotherapist, because often physiotherapists can prescribe the program that can be done at home.
It may need to have more safety adaptations or modifications. Okay, great. just want to, we've talked a little bit, is there any role for vitamin D in fall prevention and any recommendations around dosage?
So that's a very hot topic.
Okay.
And so some years there's been more research saying it helps falls, and some years now this year we're saying that if people have enough vitamin D, it doesn't really help them.
Over and over, like if they're getting enough through
their
diet and sunlight
or supplements,
going over and above.
right, doesn't really help.
Okay.
So for those who are in long-term care or nursing homes or really are housebound,
okay,
those people will often benefit from 1,000 of vitamin D a day.
Because they're probably deficient. Not because the
right.
extra vitamin D. And is it, I'm having a hard time seeing that it's going to prevent falls, but it might prevent fractures if they do fall. Is that?
Not alone.
Okay.
Not alone. So in terms of falls, it does affect your balance and sway. So it does have a direct effect. Alone, it's not enough.
Okay.
In terms of preventing fractures, you need it with other medications. So the one thing we need to talk about is one of the biggest risk factors for dementia, for fractures, is dementia. Is people with Alzheimer's will often do really well at home with the proper supports, but often the hip fracture is the tipping point when they end up in the nursing home. So remembering that those with dementia should have their bones assessed, have one bone density after the age of 65, both men and women.
Okay.
And if there's been height loss, especially if they're curving their back forward, think about have they had spine fractures. So those are important things to identify. So in terms of specific exercises for individuals with advanced dementia, I'd encourage you to look at Osteoporosis Canada and the GERIS website. We have multiple extra videos that that are about 2 to 3 minutes for both families and personal support care worker, for people with advanced memory changes that you can do
to help
easily.
guide them through
That's
some
right.
of the exercises.
That's right, yeah.
Okay, great. Well, I think we have one last question that we'll try to address. Even in long-term care, where there are falls prevention plans in place, it's impossible to stop them altogether. Family members get very upset and blame us. I guess this is maybe a personal support worker or staff person working in long-term care. So the family members get very upset when their loved one living with dementia falls. Staff feel very bad about the fall, even without the added upset from the family. And I guess, this is sort of a general truth about a lot of the things we do in medicine. There's risks associated. You've had some great suggestions here in terms of exercise and assessment of medications and doing assessing blood pressure and feet and everything. But nothing will eliminate any risk. And I think we would really encourage people to be active and doing exercise and walking and the functional exercises that you talked about that will help them with toileting and walking. But there's going to be some risk no matter what, and it sounds like that risk, whether at home or in long-term care, it's never not there at all. So
right, and so I think that one of our interesting research, we've developed a tool called the Fracture Risk Assessment Tool, specifically for nursing homes. And it finds that people who have dementia, who wander in the halls, are the ones that are going to fracture. So think about if they're falling, have they been assessed for fracture prevention? Right. So are they on the medications can reduce the risk of fracture by 40 to 60%.
Yeah, that's pretty substantial, especially if
substantial.
Yeah.
In terms of family members becoming upset, I think having that conversation before, as people are admitted, talking about falls, what you can do to prevent, and then some of the risk, if you allow them to have their independence, can't be taken away. Sure. I think as research evolves, we're looking at making floors that if you were to fall, that you don't break a hip or have a bleeding in your brain, a subdural, There's new technology that's currently being investigated, just like we have airbags in cars, having airbags for people who are at high risk who fall. I think that it's a very difficult place for staff because they're trying to be respectful of independence.
Yes, and I think in many cases have been encouraged to try to let somebody have autonomy and be active. So yeah, I can appreciate that, having that conversation up front about expectations and doing what you can to prevent fractures and falls, but acknowledging.
Right. And there was a very interesting study in Australia called the Sunbeam study that showed that when physiotherapists and the physiotherapy aides worked with people with dementia in the nursing homes, you could reduce falls by 20%.
Yeah, substantial. So there's a lot that can be done to reduce risks for fractures and for falls.
That's right.
And I guess the number one takeaway would be an assessment for all of the factors, especially if somebody's falling frequently, and do a number of these things fracture prevention-wise. Exercise would be one of the more important types of interventions, it sounds like. So that is all the time we have for today. I do want to ask people to take an opportunity to fill out the very brief survey, give us feedback on today's live event, give us your input for suggestions for future live events. Our next live event will be Thursday, April 18th, also at 1 o'clock, and Dr. Stramko and I will be talking about delirium and acute confusion and things that you might need to know as a caregiver if your loved one with dementia is taken to the hospital. And a few other parting notes. I want to thank our special guest, Dr. Papaioannou, and Dr. Stramko as well for his help today. Funding has been provided for the Center for Aging and Brain Health Innovation, powered by Baycrest. We've been really grateful for support from the Jarvis Center at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, the Alzheimer's Society Foundation of Hamilton Halton, and our team at the Division of E-Learning Innovation. The survey is pinned at the top of the comment section, so please fill it out. And I would be remiss if I did not reiterate that teamwork makes the dream work. So thanks very much to the Division of E-Learning team, and we'll see you in April.